Having been around in law enforcement for 30 plus years now, one of the things I can tell you is we've seen some big changes in regards to mental health issues.
The paradigm shift is major. It could not have been done without the services that Minnesota has put in place.
They come here seeking answers and questions, and they just want to know if there is hope or if there is a chance for them. And that's my job, is to provide them with the resources that they had no idea were out there, and then help them kind of get things rolling and make sure that they are on the right track.
When I first started, it was law enforcement was sort of out there on their own. There wasn't a lot of interaction with human services or mental health facilities, those types of things. When we ran across people that had mental health issues, our job was to pick them up, bring them someplace. Sometimes we weren't sure where that was. Sometimes it was your local hospital. Sometimes, depending upon where you worked, there was a regional treatment center where we just brought people there.
It was institution per se, a campus with lots of trees and ornate architecture, big campus with and a kind of an inclusive community where every service needed was there, but it was somewhere over there and as away, and people went there, and it had a connotation. And as kids growing up, it's like you ought to, if there was somebody who was doing something, say, well, they should take you to Fergus, or you're crazy, you should be in Fergus, or whatever. So there was that kind of institutional thing, but it was away and very different than from today.
When I was in high school, one of the things in our psychology class was to take a tour of the Fergus Falls Regional Treatment Center. And I just can't imagine this day and age, that would never be allowed. But I still can see some of the people that were experiencing mental illness that were locked up. And all of a sudden, not all of a sudden, it's taken many, many years, but that's not the case anymore.
When I first started in psychiatric nursing in the cities, and it was typical all over, we had what were called then the state hospitals of Minnesota, and we had patients being admitted who would be there being admitted to the hospital I worked at for 4 to 6 weeks, and I believe at the state hospitals easily 2 to 3 months, maybe longer. But that was a standard of care then.
My mom years ago told me about a relative of hers that when she was a young girl had been taken up to the Fergus Falls Regional Treatment Center, and my mom never saw her again. And so not quite 20 years later, I'm working with Pope County and end up working with a case manager who happens to have this woman as one of her clients. And she's still in the regional treatment center. She spent her entire life essentially at that regional treatment center.
And then when the big movement came to depopulate the regional treatment centers, that's when we got all the community-based opportunities.
A lot of it, at least I think, it started with the community support program and moving into where the person was instead of bringing the person to us.
When we began to develop community-based mental health initiative and regional treatment centers began to close down, we saw an influx of people coming back into our community. What we also found was that we were not prepared to deal with that because we could no longer just sort of pick them up and drop them off someplace. So as communities saw that, they really were forced to develop programs, mental health initiatives, getting groups together, law enforcement, human services, group homes, those types of things began to come together.
People did the best they could at the time and the best they knew, but many big developments happened, like psychotropic medications that allowed people to live that might not have been able to live in the community and stay at home and everything. Made that more possible, and it brought people into their own treatment plans. It went from more intensive interviewing and heavy medication to a combination of things with services coming to the people where they lived, and people were involved in their own plans.
I think that it's definitely improved care, and it's changed. The view is more seeing people as people. They're not patients. They're not living in an institution. They are people. We are in their homes. They're nice enough to share their homes with us and to share their lives with us.
The whole system has changed to view people with mental illness as real people. Sometimes you'll hear the word consumers. There's other terms as well, but people who are, first of all, a person who happen to have a mental illness, and who are trying to put their life back together, and are care about others, want some sort of relationships, usually want some sort of productive feeling and feeling of self-worth. And that's probably one of the biggest, another paradigm shift that we've had that's been just major in terms of you are capable of managing your chronic health condition, just like someone's capable of managing their diabetes.
Now, of course, we do a lot of person-centered approach, and it's really about what's important to that person, what their goals are, what they want to see, what they see as their illness, and how to manage their illness. So we try to help them on their terms.
A little bit newer term, but not a new concept, is illness management and recovery.
The state has a new program that PCS was fortunate enough to be part of the pilot project, which is called Illness Management and Recovery, IMR. And we've seen several people be really very successful with that. And it's all based around what their perception is of their illness, what they think relapse is, what they can do or what their plan would be if they start having a relapse. So for a lot of consumers, it's been a real written plan almost that they've written and we've just kind of assisted with.
I tell people a lot that I work with, I say, I want to hear what your goals are, because my goals for you don't really matter. If it doesn't matter to you, it's not going to happen. And they seem to really appreciate that approach, and it just makes sense. If they're not emotionally invested in their own recovery, it's not going to happen.
They've had the opportunity to really focus on what their needs and wants are, and then really it becomes us as providers trying to find out, okay, how can we help them achieve that?
Every day is different, and I meet with people in their homes for the most part, sometimes in the office, sometimes in alternate locations, and we sit down and talk about what is most important to them, what do they want to accomplish in life, what support do they need to accomplish it, and then how are we going to make that all happen? Break it down into baby steps and help them do what they want to do.
There's many more resources out there, and many more. The network has really expanded, and how people the collaboratives and so on like that. For example, I could just go down on community-based services. None of those were there before 1987. Community support programs, the assertive community treatment or the ACT teams, the intensive residential treatment sites were not there. There's adult foster care homes for mentally ill folks that are kind of an outreach of public health, and there's drop-in centers, and there's ARMS services, adult mental health or adult rehabilitative mental health services that are community-based, and socialization groups and employment settings.
There's just other programs that are available out there that are working together, cooperation, and therefore a few resources become a larger number of resources, and the outcome is just a whole lot better than what we could, do it without it.
There are support services out there. There are so many resources that can get you back on track. You don't have to be living in isolation or with depression the rest of your life.
They now have the resources. They have warm lines to call. They have hotlines. They have websites. Many of the consumers now are involved in their local advisory councils and with the initiatives. And those are great support groups for them and networking sites for them to help maintain.
By far, the majority of the people that have been transitioned back into the community have done well. But it's also dependent upon community and what the community is willing to do to integrate those individuals into the community, whether it's employment issues, whether they have a support system, maybe they have family, but maybe they don't. Are there other members in the community, whether they're health professionals, law enforcement, human services, etc., that are willing to step into that role, as a support person? And communities that have that and have a commitment to integrate those individuals do well, and the individuals, in fact, do well.
I just had a resident discharge about 2 weeks ago. I got him set up with CSP, the community support system here in town, and they are amazing. And I also looked into the ACT team. I also contacted West Central Communities Action, which was amazing because when he got into his apartment, he needed help with a deposit for electricity and possibly with bills. All they needed from him was an application, a little bit of information, and then automatically he was set up with a $150 deposit and enough grant money to help him pay for his electric bills. And then there's Bridges here in town in Alexandria that has helped him pay half of his rent, which is truly amazing.
We're finding that if people don't have housing, they can't do anything else. It's just that housing is just a critical factor. It's needed. It has to be built. Their lives are built upon that. Many people can't get some of the programs because they don't have an address.
Yeah, this kid came from living in a van to being able to go to college, live in an apartment, have his bills helped pay for, going to support groups, having friends, and not having to worry about where am I going to live now, where am I going to get my food. He was set up with food support so he can go out and buy groceries. I mean, it's truly amazing the resources that are out there to help somebody go from nothing to actually having a chance.
I've seen people that hold jobs for a long time to avoid hospitalization, and their families stayed together, and they were able to stay in their homes and not be disrupted in their housing, and have been more or less gotten really involved in advocating for their own illnesses.
And I see the good they do every day in my work. They're absolutely essential to keep people out of the hospital. And every time we keep someone out of the hospital, not only do we do wonders for them, but we save the state of Minnesota oodles of money. So it's a very cost-effective treatment, having social workers and community support workers and group home workers for those people who do need the level of care that a group home would provide.
What it's also done for us in law enforcement, it is given us the catalyst to retrain ourselves in regards to these kinds of issues.
As far as like law enforcement, I really feel it's really kind of tough for them because of the fact they have so much going on. And if they can be able to recognize just an inkling of what's happening in someone's life and in a positive manner, being able to refer it to the proper agency, we're going to be able to address that and get it going.
And one of my hopes and kind of dreams is that sometime in the near future that we would actually sit down here in either Stevens County or West Central Minnesota and have a mental health symposium where we would just bring the workers together for one day. And it doesn't have to be a big training day, but it can be, everybody should set up a table and put their brochures out and go around and meet each other and really come together and just, talk about the different programs that they're doing to provide information. And, if you can do that in an afternoon in a 4-hour session or whatever, I think that's hugely beneficial to people like me who at 3 o'clock in the morning, I got a mental health crisis going, and it's like, gee, when I was at that symposium, I picked up a bunch of brochures from this particular home or whatever. I can provide that information to the physician who has to make those choices, or to their worker, or to their parent or guardian, etc. And that can be very helpful. the more resources we can identify within our area here, I think more beneficial it is to us.